Okay, I just got the recording started. So thank you everybody for being again so patient with us and so nimble transitioning over to this Zoom link this morning. Um, Venkat and I are really thrilled about this meeting today. We have some really wonderful guests who also have been so patient with us, so we thank you guys. I want to go ahead and introduce Dr. Eric Buffet, who is currently the Director of Pediatric Neuro-Oncology Program at Sick Kids in Toronto, and a professor in the Department of Pediatrics at the University of Toronto. He was one of the former presidents of SIOP and has been really involved within collaborative groups across North America and the world, kind of focusing on how we improve the outcomes for children with neuro-oncology really across the world. He did his medical training in France, then worked in England before transitioning over into Toronto. He has been recognized by the Society of Neuro-Oncology with a Lifetime Achievement Award in 2021 and continues to be strongly involved in SIOP as well as emerging programs to improve the outcomes for children with neuro-oncology all over the world, like the ARIA program. And so I will let him continue to tell a little bit about his journey and what brought him to neuro-oncology, what brought him to working kind of on a global scale. And we are going to have some time for questions afterwards. And so with that, I will stop sharing my screen and transition over to you, Dr. Buffet. Thank you again for being here today.
Yeah, I will. So good morning, good afternoon, everyone. It's really a pleasure. I need the screen, so I don't know who is managing the screen, but I cannot access the screen so far. So I will say a few words. First, thank you, Caitlin, thank you, Venkat, for having me today. Thank you, Anieban, for being the new generation or the person who is going to speak about today. I'm going to speak more about yesterday and what brought me to this field and what is a passion that guided me all my life in doing pediatric neuro-oncology. So I took some of the slides from a speech that I gave a year ago because I'm not anymore the head of neuro-oncology at Sick Kids. I have decided to step down, not to retire. And I would say a few words about this. So what happens after you decide just to leave the place to other people? So just to say, I'm not young, so I'm in the late 60s. So my life as a pediatric oncologist and then a pediatric neuro-oncologist has built up over the years, and it has been now more than 40 years that I have been in this field. And I want to show you a few things. When I started as a medical student, there was no CT scan, no MRI scan. That's how we were diagnosing a brain. We were just making the diagnosis of brain tumor with pneumoencephalography. We used to scan the spine with myelogram. That's how we were detecting spinal cord tumor or spinal metastasis in medulloblastoma. So nothing to do with what we do now. And as a result, I have to say that I had to learn during this time. I didn't come with a training in MRI scan, a training in CT scan. This was all new to me. And this training has been absolutely wonderful, but also something which has changed the practice. A change in the practice, for example, we used to diagnose subdural hematoma, particularly in children victim of child abuse, just with a torch. We didn't do any scan at that time. And we were just aspirating this subdural hematoma. So this is a practice that was routine practice in my generation, and that has completely changed since that. But, when I started to look at pediatric neuro-oncology, why first is because my boss said, you should do this. And I had a boss who was absolutely wonderful, Maud Bruna. She was one of the founding members of the International Society of Pediatric Oncology. And she told me that there was absolutely nothing in this field, or very, very little. In fact, this was the early time of the SIOP-1 trial. And this trial, you can see there is no date, but it started in 1979. I was still a medical student at that time. And so this was the first trial that looked at medulloblastoma, and a trial that looked at whether the addition of chemotherapy was improving the outcome of the patient. And this trial was interesting because it was discontinued after a few years. It was led by a radiation oncologist called Julian Blum. And after 3 years of the trial, there was, for the Data Safety Monitoring Committee, a significant difference between chemotherapy and control, and the trial was discontinued. But then Julian Blum passed away, and Diana Tate, who was a fellow, she's here, of Julian Blum here, decided to take the data again and look at the data, and she showed that over time the difference became non-significant, still some advantage. So this was one of the early trials, and yes, this trial had only CT scan. Many patients had no CSF, no myelogram. This was the early stage of the clinical trial. And so we identified some of the prognostic factors here. And there were also, this was the beginning of some, complex chemotherapy treatment. And one you may hear about was called 18-1. It was a nightmare for the nurses. You had to give 8 different chemotherapy over 24 hours. And this trial gave amazing results, apparently, and including in patients with medulloblastoma. So as a result, I was asked to develop a trial. This was my first task as a young oncologist, to develop a trial where we're giving the 18-1 protocol and we're not giving supratentorial radiation to the kids in order to preserve their upper brain. It was heroic time at that time. So what was the outcome is all the patients except 2 relapsed. And the 2, it would be interesting just to see whether they were just special subgroup today, but this was a consequence of no radiotherapy to the upper brain. As I say, heroic time, we were learning, we didn't know exactly what chemotherapy was about. And heroic time, because we try everything with chemotherapy. We try high-dose chemotherapy in brainstem tumor, in DIPG. And this trial was very, very challenging, a terrible trial. I tell you, we treated over 30 patients with intensive chemotherapy and bone marrow transplant. Another clinical trial in other type of high-grade glioma here, with results that were devastating. You can see that all patients died within a range of, a few days, within 20 months. So it was really a time where you were wondering in some days what I'm doing here and is there any future? But we are making progress, and particularly in medulloblastoma, where we identify some regimens that are still working today, carboplatin and etoposide. These are friends, Jean-Claude Jantet here, François Dose. We are still connected today in France. In germ cell tumor, where I was working with people who were absolutely amazing. Catherine Pat, who is still around. This was, a group of people with whom we made significant progress here. And with that, we built a group of friends who were the first generation of pediatric neuro-oncologists. And all these people are still connected. Some are still active. Some have retired, like Jeff Allen. Cynthia, unfortunately, passed away. Jonathan is half retired. But many of these people are still relatively active, or very active, I tell you, because they are still passionate. For me, what has changed is my recruitment in Toronto in 2000 by this guy, Dr. Victor Blanchet, who is a close friend now, and with a team of people, Mark Greenberg and Sheila Weitzman, who are also people who have been very committed to their work. And what was really for me exciting was the fact that I could do everything I wanted in this context. I could develop a program. I had a blank check, and Dr. Blanchet told me, I want you to develop, the top one center of pediatric neuro-oncology in the world. You have the freedom to implement your vision. So I recruited different people here, and everyone, it didn't come in one day. You can see it took 15 years to recruit VJ at the end. And this was my team when I decided to leave and to leave the space spot to Dr. Tabori. But you can see in each, everyone had a different portfolio. Just it shows you also how complex is the world of pediatric neuro-oncology. You have so many different tumors. You think about brain tumor, but when you dig deep inside into it, you can see that you have a huge diversity of tumor and enough just to have work for a big team. In Toronto, we see around 100 new patients a year, so that's also a big program. And of course, if you have a smaller program with only a few brain tumors, this is what you have to deal with, all these tumors. And this is why you need to have connection and friends around who can discuss with you and connect with you. So for me, this was an opportunity, as I say, at this blank check to develop a vision or develop something that I was dreaming about. And I will show you a few things about neuro-oncology that are exciting. First is a collaboration, and we had the opportunity to develop the Canadian Pediatric Brain Tumor Network with my colleague and friend, Doug Straffer, who was coming from Texas Children when I arrived. And with this, we had monthly meeting between the different centers using Zoom or using Teams. And with this group, we did a lot of retrospective review. We got a grant, we wrote a book, we did clinical trial, we developed standard of care, we developed guidelines, and we wrote over 30 papers. And this was a fantastic collaboration, something that seems to be impossible to start because there was a lot of reluctance from the people just to work with the big brother, Toronto. But eventually it worked very well because many of the studies were led by different people even in small centers, and this was a fantastic opportunity. It was also global collaboration, and we developed collaboration in Toronto with many different centers. They are colleagues, they are collaborators, they may be sometimes competitors, but the competition is always an elegant competition. And with this, we were able to make a big impact, a lot of discovery, and that's not me. There are people in the team, Michael Taylor and his work in medulloblastoma, the work in ependymoma by Michael Taylor and Vijay Ramaswamy, the work in low-grade glioma with Uri Tabori and Cynthia Hawking, the IPGA with Cynthia Hawking and Ute Bartels, and all the work with Annie Yuang on rhabdoid tumor, ETMR, and pinot tumor, where she described all the subgrouping of this different tumor. So it was really an exciting opportunity because pediatric brain tumor is still a world of discovery. There is a lot to learn, a lot to discover, including in terms of treatment. So we developed innovative treatment for low-grade glioma. We developed the vinblastine and vinorelbine trial for MMRD, and I'm sure that Anirban will comment about this. We were one of the first centers to implement ray radiation. And I want to show you the first vinblastine patient. It was nearly 25 years ago that we treated. And you could see how spectacular the response was after 3 months or 6 months of treatment. This was really something that was unbelievable. That was the beginning of the vinblastine experience that we published as a phase 2, and then as an upfront trial with my colleague and friend Alvaro La Saleta, who trained in Toronto. And there is an ongoing trial now that is looking at vinblastine plus Avastin. We also work with other friends and other people because we saw that there was an opportunity to develop a trial of vinorelbine, and this was a work that we did with my colleague and friend Andrea Capellano, and she did a wonderful work and published this, showing that vinorelbine has a great activity in pediatric low-grade glioma, similar to vincristine carbo or vinblastine. Now, one of the things that was a bit challenging for me is to find the money to run this trial, and you can see that 20 years ago, it was relatively cheap. When I say cheap, it was still $250,000 to run a trial. The last trial that we ran cost $3 million, which is really something which is much, much more challenging than to run this early trial. And this is what happened to all the regulatory and administrative complication associated with the opening and the running of clinical trial. So Anirban will tell you about this, but we have been through a fantastic period over the last 9 years, thanks to Dr. Tabori, who was the leader of the MMRD project, and Adam Schlim, who was also very involved in the lab. And we did run some clinical trial and that have been now published, and Anirban is becoming the leader of this clinical trial. We did also some work, and this was new. When I started to work in the field, we used to say we can only give radiation once. And we did look at re-irradiation, not only in ependymoma, but also in DIPG, and showing that you can help and improve survival. We also look at re-irradiation in high-grade glioma with Derek Sang, who is going to be a speaker at the SIOP meeting in Ottawa. And this experience was absolutely fabulous because we could offer more hope to patients and families. And as Caitlin said, I started my life in Europe, and I still continue to work with the European group, particularly in James Septimer, in the IPG, but also in the ependymoma, and this publication was very nice. It was 22 years after I left the UK, but finally, Risha Grandi just published a protocol that I personally wrote 25 years ago. What has been really an amazing experience in Toronto has been not only the fact that we were treating patients with brain tumor, but we were also interested in looking at their functional outcome. Because when you look at neuro-oncology and pediatric neuro-oncology, what you want to do is to cure the child without any deficit. And the deficit is a big issue in our job, because you can see that the tumor itself, but also the treatment is causing some impairment. And with Don Mabot, with neuropsychologist Don is here, we decided to run several clinical trials of rehabilitation or brain repair. The first one was a trial of exercise training, and this was with Janine Piscione, who is a fantastic physiotherapist, and Laura Johnson, neuropsychologist. And we did some formal training. It was very, very rigorous, and you can read this paper. I'm happy to share the papers with you. And it was very well designed, very well conducted, and showed that kids who were following this intensive training program had benefit in terms of IQ and also functional improvement in terms of physio. Their balance was much better, their strength was much better. And eventually we decided just to look also at another option, which is the use of metformin. And this was due to the work that was conducted initially by Frida Miller on a mouse model that showed that metformin could improve neurogenesis. And we decided to develop a trial of metformin for patients who had been treated with radiation in the past. And this trial was published. It was fantastic in Nature Medicine, showing that the kids were benefiting from the treatment or the administration of metformin in this context. So very exciting thing, new things, and certainly still a lot to do in this situation. We also work on visual rehabilitation. I will be quick here. This is with my colleague and friend, Michael Reber, and Inshi Yaman, who is a fellow, and we are using goggles just to try to improve vision in children with hemianopia. The publication is coming soon because we just finished a pilot study. Very, very exciting. Of course, you know, what was an opportunity also is to train people and to share the passion with the people. And this was really an amazing opportunity. And now we have a fantastic network of different fellows around the world. And with this, we can continue just to work in collaboration. And I love this network of people. There was a first generation with people who are now star in their situation, the context, Darren Hargrave, Ute Barthes, who is now just leaving Toronto to go to Heidelberg, Lucie Lafay-Cousin, who is in Calgary, and Uri, who was my fellow and is now my boss. But there are many, many other fellows that we trained over the last few years, including Annie Urband, who's now has a staff position in Toronto, and many who have returned to their countries and are leading or are leader in their field in pediatric neuro-oncology at their place. What has been very special in Toronto also is the development of twinning program where we work with other people. We do teleconference using Zoom. It started with Jordan. It was a long time ago. Here is Jordan. It started in 2003. And you can see now that the twinning program has developed around the world, and it's absolutely fantastic, sometimes challenging when you are in Toronto, just to connect with Indonesia. It's usually at midnight or at 1 o'clock. But with this, you make friends around the world. I never went to Indonesia, but I work with them on a regular basis, I tell you. I also have a great connection with Ghana, where I've trained a number of people, but I never went to Ghana. So you can do neuro-oncology, it's here again. You can do a neuro-oncology around the world and not without traveling all the time, even if I like to travel, and I'm a big traveler. Now I have to tell you, neuro-oncology is always, to me, one of the most exciting aspects of pediatric oncology because there is so much to do, so much to discover, so much transition. Now we are moving from chemotherapy to targeted treatment. We are implementing molecular biology and sequencing into our practice. But on a daily basis, there are good days because you have a bad diagnosis, you have a bad scan, and you have good day. So it's just like life, but with a bit more just roller coaster than you would have in the normal life because you share your emotion and your passion with your patient and your families. And with this, you need also to have a team and to get along with your team. So I had the privilege to have a wonderful team in Toronto of people who could work, but who could take fun. This is David, our social worker, who is always just a fantastic player during Halloween. And the team of people who have been working with me here. And from time to time, we were just taking pictures of the team. And I really look at this picture with a lot of, emotion. And these people make your life. Neuro-oncology is a world of collaboration, and you have to make sure that you get along with pathologists, with surgeons, with radiation oncologists, ophthalmologists, oncologists, palliative care people, psychologists, radiologists. All these people are essential, and endocrinologists. All these people are essential, and you have to work closely with them if you want to provide the best care for your patient. what I learned also in my career is that if you want to develop a program and you want to do some research, fundraising is important. And I want to thank all the donors who have been, contributing to the research, my research, but also Uri's research, Ute's research, Annie's research, and Vijay's research. And these people have been wonderful support to our program. You also need to think of yourself and to make sure that you don't stay behind and you take care of yourself. So for me, you may know I'm a runner, so that's a picture that I have taken a few weeks ago at the Toronto Island Triathlon, which I won in my age category. But it's very important that you take care of yourself when you do this job, because it's a tough job. It's not easy. And don't work 24/7. You need just to make sure that you have a family life, that you have a personal life, and that you balance all aspects of your life. And at the end, I have to say, I am at this stage of my career, and I don't know if you know this picture. It's a picture of the Schindler List, where he takes his ring and he says, I should have sold my ring just to save one more. And you think of the many patients that you have treated, and some that you have treated 25 or 30 years ago, and you didn't know at that time that they had the BRAF mutation, and you could have saved them. And so this is a feeling you have at one stage of your career. It's just that if you had the knowledge at that time that you have today, this would have made a difference. And that's the thing which is a bit sensitive at one stage of your life, but also positive because you see that you have made a difference with the discovery, with the change that you have triggered, you or your friends or cooperative group. And that's really a sensation that is absolutely fantastic. So I will finish here and I will leave the spot to Annie, hoping that I have not been too long. Thank you.
Thank you very much for that presentation. I will open it up now to anybody in the audience. If you have any questions for Dr. Buffet, please unmute your mic. I'll give people a second and then I have a question for you.
Be shy, you are 71, so.
Actually, this is one of the largest attendance we have ever had for our meeting. Professor Buffet, sorry, Kathleen. Yeah.
No. You go ahead, Venkat. Go ahead.
Professor Buffet, coming from an LMIC or resource limited setting, sometimes, currently all the articles are about classification of brain tumors, medulloblastomas, low-grade gliomas, and genomics. But we don't even have sometimes access to basic IHC we just get a diagnosis of high-grade glioma or ependymoma. So when we read these papers, we really wonder, what are we going to do? What advice would you give to people like us where we just don't have the resources, or even if we have the resources, not the money to do all these genomics and testing? It's just the same chemotherapy, radiation for us.
Yeah, so that's a very, very important question. And I only show one slide about the twinning, but this twinning experience, has certainly been beneficial to a number of people in low and middle income countries. But I learned so much from this, and I learned with humility that, people are doing miracles with nothing. Now, this is also a give and take, and we can share a lot of things. I was working with Lebanon half an hour ago, and Lebanon is becoming a low and middle income country because of the crisis going on. And they were asking the same question about subgrouping of medulloblastoma. And I was just mentioning about how you can make subgrouping with radiology or an estimate of subgrouping with the radiology. And, there are a number of tricks that you can use. Of course, not everyone, but What I'm trying to do at the same time is to advocate for access to targeted treatment, for example, in low and middle income country. And for example, I work with UICC. There is a program which is called ATOM, which is access to oncology medicine. And with UICC, we have signed partnership with different drug companies. And in particular, Novartis can provide free access to targeted treatment. The question is, how do you identify a BRAF mutation or BRAF fusion? And that's where we have some limitation. But at the same time, I have decided when I stepped down from SickKids to work with Sanjit Global to see if we can improve the access to molecular diagnosis, because I think in the next few years, this is going to be one of the first priority. So stay tuned, it's coming. Look at what is going on with different programs, SickKids, Sanjit, Princess Maxima. But there is a lot going on, and particularly with a lot of attention to how can we help people in low and middle income country. I have to say, one of the wonderful opportunity when you work in a low and middle income country is just to be part of a twinning program. Some people don't like the term twinning. Let's say collaboration with a center in high income country. And I'm currently involved in 12 different collaboration, but I'm happy just to add one or two more on my list if you want me just to help you. What are the criteria to attend the online course of paid neuro-oncology, especially for us who are in sub-Saharan Africa? So email me with this. We have divided sub-Saharan Africa in two parts, not because of the geography, but because of the language. So I'm in charge of the Francophone Africa with the GFRP, with Laila Essisen, and Alan Davidson is in charge of Anglophone Africa, and I can communicate or put you in touch with Alan Davidson. They have every Monday pediatric oncology. It's not yet a full neuro-oncology program, but every Monday they have a pediatric oncology network, and this is very, very interesting. I try to attend to discuss also the pediatric brain tumor cases.
Thank you. If you have any of those links, we're happy to share them within the WhatsApp group so that people who are interested can join as well. And with that, I will turn it over to Venkat, who's going to introduce our other speaker. And in the meantime, I'll continue to monitor the chat if we have any other questions come in.
It's a pleasure introducing Anirban. Anirban is a dear colleague from Kolkata, the city of joy. Anirban is a real superstar, a real young investigator, and he is an inspiration to a lot of young investigators from LMIC. He's done a lot of work with mismatched repair genes and immunotherapy in brain tumors, and published in big journals like Nature. So, and he's won many awards. I think all the SIOP awards, Anirban, Young Investigator Award, Best Oral Presentation, Shoswat Award. So, Anirban, I'm sure you're going to inspire many more people to venture into something unknown, discover, look at things from a different perspective. And he's a great guy to hang around with, I can tell you that. So, thanks, Anirban, for accepting this invitation.
So thank you, Dr. Venkat and Kathleen, for inviting me. And Dr. Buffet has been my mentor, is still my mentor. And it's like a bit intimidating to speak after his immense talk about his immense experience and work over decades. So I will try to sort of share with you my small bit on what I have been doing and learning from the giants in the field. And it's been a privilege to go through this journey over the past 6 or 7 years. So I will be talking about replication repair deficiency, or RRD, which is sort of my area of work. But rather than focus on the disease per se or the group of diseases per se, I would like to really highlight the point that Dr. Buffet mentioned, that how we can maybe work together from across the globe to make a real difference in the lives of our people. So the work that I will be presenting is also a part of the International Replication Repair Deficiency Consortium, and I will be talking a little bit about that as well. So as Dr. Venkat mentioned, my hometown is Kolkata. I trained in PGI Chandigarh. I know many of you in the participant list as friends for many years. And then I was working in Tata Medical Center in Kolkata, which is like the tertiary cancer hospital in Eastern India and caters not only to the eastern part of India, but also to neighboring countries like Nepal, Bhutan, and Bangladesh. And when I joined there as a oncologist in 2016, after completing my studies in PGI Chandigarh, I was tasked to sort of develop the neuro-oncology program over there. And of course, that was a huge, huge challenge for me because my expertise and knowledge in neuro-oncology, which explosively increased over the last decade, was pretty limited at that time. So we saw increasing number of patients, and as we all know, in LMIC and in large centers, we get patients which often surprise us. So I was really intrigued by several patients that we were struggling to manage. As Dr. Venkat mentioned, we didn't have moleculars, so we could only do limited set of tests. But as Dr. Buffet mentioned, this was an opportunity to reach out over email to experts around the world and try to find out how we could benefit our patients back home. So this I found personally to be very enriching and enlightening, not only for gaining knowledge, but also to share that with colleagues and do things that can actually help our patients. So we sort of dealt with the routine syndromes, Lee-Fraumeni, Dicer 1 presenting with sarcomas, but unusual cases like a child who had both germline NF1 and RB1 and presented with retinoblastoma in one eye and optic pathway glioma in the other eye. MECAN amplified retinoblastoma, which is, as we all know as oncologists, a rare subset, and we did some work with the expert group in Spain. So I developed an interest in why these tumors develop and how we can use cancer genetics to identify germline predisposition. And there is a yin and yang component, as my other mentor Uri wants or likes to say, that it's not only that we identify a germline syndrome and link it to a tumor, but we can also go back. We can look at the tumor, and then maybe in some patients, we can actually identify a germline condition that is very important to diagnose. And I will be talking about one of those today. So in Kolkata, we, even without the fancy molecular tests, with using IHC and some NGS based on mainly compassionate things to companies, by talking to them and speaking to them, we were able to diagnose that around 11% of our 100-odd patients did have a cancer predisposition in the backdrop of their brain tumors. And as I said, it was an opportunity to get involved with international interest groups. And as we all know, practicing in an LMIC setting, that what we read in the literature is probably 3 to 5 years behind of what's being done. So it's very enlightening to me to reach out to the experts and know that what is current and what we should do for our patients. And we also, with the help of those experts who are very willing to help us, develop a cost-effective strategy of how we could use, as Dr. Buffet mentioned, radiology, IHC, and maybe just Sanger sequencing for P53 gene to identify the bad players in medulloblastoma, for example. It's not an easy process, but something that can be done if we really get deep into the biology and speak to the relevant people and find out ways of working with our pathologists and radiology colleagues to do what we can do for our patients, even when the resources are limited. So while this was an enriching experience, we had challenging patients, and this is the patient that actually brought me in contact with Dr. Buffet and Dr. Tabori and sort of led to my journey of going into RRD. So this was a young child who was actually being treated by one of our colleagues in the adult oncology side for an adenocarcinoma of the colon, and presented. I was on service one evening with seizures, and the obvious question was that whether this was a METS. So we diagnosed that this was actually glioblastoma, and as you may or may not know, it's very unusual to have a patient presenting with two tumors, and that led us to a journey to identify this patient had a germline predisposition condition known as constitutional mismatch repair deficiency, and that began our journey, my journey, and the journey of my institution to see that whether this was like common in all our patients or how prevalent was that. So Dr. Parumita Roy, who was a pathologist that I really enjoyed working with while I was in Tata Kolkata, took up the mantle and did a study across all our high-grade gliomas, and we found that 30% of our high-grade gliomas do arise from this backdrop of constitutional mismatch repair deficiency, which was usually at that point of time, for my knowledge, was a very rare syndrome, which was sort of a one-off case that one sees in a lifetime. And that has now gone forward to sort of, under her leadership, to develop an ICMR, which is the Indian Council of Medical Research approved protocol to actually study the prevalence of gliomas or RRD in gliomas across the age group from children to adolescents to young adults up to the age of 40. And there is a reason that I will come why we are doing this. across 5 to 6 centers in India. And if some of you are participating in that, please feel to reach out to her, and she can really help with some of the logistics of how we can do the IHCs and do simple diagnostic tools to identify a disease subset which is not as rare as we imagined it to be. So in 2018, when we had diagnosed that patient, I had reached out to IRRDC, or the International Replication Repair Deficiency Consortium, led by Dr. Buffet and Dr. Tabori in Sick Kids, over email asking what I should do for my patient. And now that I'm more involved, we are happy to share that this is actually a collaboration, as Dr. Buffet talked about, from multiple physicians and scientists from across the globe. We have more than 40 countries now. And the impact has been that we have been able to work with the partners from across the globe to know more about this disease. And as I will share with you, how that actually directly feedbacks into how we manage our patients and take the field forward for this not uncommon disease, if I can say that. So I will talk a little bit about the science bits, but I will try to keep it like in very simple terms. RRD is a pan-cancer mechanism, and it's not purely related to the rare syndrome of CMMRD. And we have other germline conditions. We can have the same biology. And we also have sporadic cases and treatment-induced cases, specifically an agent that we all know, temozolomide, that is used in treatment of gliomas, can lead to an acquired RRD. So what happens when the cell divides, the DNA replicates, and this is an error-prone process, and there are inbuilt mechanisms in place to make sure that the errors don't go out of hand. So this is actually done by two systems, a set of 4 mismatch repair genes, as you can see over here, and a set of 2 polymerase proofreading genes, as you can see over here. So deficiency of either mechanism can lead to increased number of errors during DNA replication, and that is manifested in the term of mismatches, like you can see over here, the C has become A, and many such mismatches leads to cancers with high mutation burden or high TMB. There can also be insertions and deletions in the repeated segments of the genome known as microsatellites, which leads to microsatellite instability. And these cancers that arise on the backdrop of RRD usually have both. They have high TMB and high MSI. The other thing to understand is that MMRD and PPD often go hand in hand, but not always. So either can arise first, and there is a random chance that the other mechanism may be hit just because there are random mutations happening, and they can happen together. And that's why when the two of them are combined, MMRD and PPD together, the TMB and the MSI levels are extremely high. And I will share with you how Dr. Buffet and Dr. Tabori took that idea forward to harness that mechanism to make an effective treatment for these patients. So before we go into the specifics, I wanted to share how the consortium works. So we work with doctors and scientists, and we get the data for the patients. We get consults from across the globe. We have weekly meetings where we go through the MRIs like a tumor board. We have Dr. Cynthia Hawkins helping us with the pathology and the molecular bits. And the intent is to do things in a stepwise manner. One is to feed back to the physician team to say what we can help with and what should be something that we can do together for the patients. And the other bit is to use this accumulating data to learn more about the disease and the syndrome. And that's like a model that I will be speaking about RRD, but I think has been done by many people for many different tumor subsets from across the globe. And that is the way the field, as Dr. Buffet mentioned, with different experts. We can't do neuro-oncology like Dr. Buffet did for 20 years doing everything, but we need to focus, we need to learn more and focus on specific aspects. But again, that links back to how we treat our patients with other cancers as well. So thanks to collaboration with many of you, we now have more than 200 patients with this rare, so-called rare syndrome, and we are learning new stuff. We knew that they have a overlap clinically with neurofibromatosis type 1, but what really surprised us that we thought that this was a rare syndrome which was present in consanguineous families. But in this data set, we found that there are patients from high-income countries where consanguinity was not known to be prevalent. And there we found that the burden was really high among indigenous populations where there is a lot of endogamy, even without overt consanguinity. So there have been generations who have married within each other, within families or extended families, that leads to a higher prevalence. And we also had immigrants and other minority populations in Canada and the US, where because of the familial dynamics, the syndrome is actually there and is probably under-recognized because nobody thinks of such a patient when they treat them in the US or in Canada before our data came out or will be coming out. So we also learned that all those 4 genes are not same, and there are variations and differences of how each gene sort of impacts how the clinical phenotype will present to you. And this is a data that we have submitted and is under review. And we learned that the genotype actually predicts the clinical outcome, and we have insights on how the different genes may need to be managed differently in the future, but still early days and limited numbers, as you see. We also learned that the cancer spectrum in CMMRD is actually pretty vast. Initially, we thought that it's mainly brain tumors and gliomas, but now more and more we find that GI tumors, hematological malignancies are not that uncommon, and also other cancers. And you can see a host of other cancer names over here, including adult type cancers, which we do not expect in children presenting at age of 15, 18, 20, or 25. So we have patients with prostate cancers, breast cancers, endometrial cancers who do not present at their normal age of presentation in the late 50s or 60s, but in their late adolescent or young adulthood period. Even within brain tumors, it's not only now gliomas. We have an enlarging cohort of medulloblastomas, which arise from the same germline predisposition and have the same biology. And this is an ependymoma, which we described for the first time with our colleagues in the UK. So because there is a germline defect, each and every cell has that, and basically any cancer can develop, but the most studies have been done in brain tumors because that's who the people were who were focusing on that. So Dr. Buffet and Dr. Tabori, but it's probably underdiagnosed in other cancer subsets, and that's what we are learning more and more. More importantly, we are now learning that it's not only a pediatric rare syndrome, because we have patients between 20 to 40 or between 18 to 40, young adults, as we all know, who are presenting with the glioblastoma having the same biology as we find in children. But they don't have the biallelic rare germline condition. They have Lynch syndrome. And as we know, Lynch syndrome is not a diagnosis that is usually linked to gliomas or glioblastomas in age 20 and 30. It's usually colon cancers in age 50 to 60 or late 40s even. So we are learning that a heterozygous state or a heterozygous defect in the mismatch repair pathway can lead to a biallelic defect in the tumor, and then the tumor is free to do what it would have done in the germline biallelic state. And working with Dr. Hawkins, Dr. Cynthia Hawkins and Uri, we have sort of set of guidelines that we have published and trying to make sure that these patients who would otherwise not have undergone the diagnostic tests, which can be as simple as a mismatch repair stain for 4 proteins, which is usually not done because it was never recognized before. Moving ahead, talking a bit more about the biology, as I said that these cancers have the highest mutation burden of all cancers. You can see pediatric cancers are usually driven by fusions and translocations, as we as pediatric oncologists know. In the case of CMMRD, the mutation burden, and this is a log scale, is extremely high if they have MMRD and or PPD. And this is much higher than the usual hypermutant cancers that we talk about in adults, including lung cancers. You can see over here, the lung cancers are here, but our cancers are really extremely high mutation burden, which we call as ultra hypermutation. And this has some implications on how we treat our patients. The unfortunate reality before Dr. Buffet and Dr. Tabore really made inroads by harnessing the fact that these are hypermutant cancers based again on the biology that we studied with the help of global collaborators from across several nations. We found that these gliomas are much more aggressive than normal gliomas. The median PFS with chemotherapy and radiation is only 9 months because one of the drugs that is commonly used in high-grade gliomas, temozolomide, doesn't work in this subset because that drug needs an intact mismatch repair pathway to have its effect. And once you relapse, everyone died within 3 months and there were no survivors at 1 year. So this was a syndrome, a rare syndrome expanding into larger subsets, gliomas being still a challenge because everyone died. But we started to collect samples, analyze the biology, identify the hypermutation and microsatellite instability, and started to think together how we could improve the outcomes for these patients. So this is the next part of my talk. And the first part was led by Uri. So he worked with Dr. David Malkin, who is like the big person in cancer genetics and is worldwide famous. And he had developed a surveillance protocol for Lee-Fraumeni syndrome, where, as you know, the cancer predisposition leads to multiple tumors over time. And they had a surveillance protocol which they found very effective to identify cancers early, treat them early, and improve outcomes. So that's what the team did for CMMRT patients, we developed a surveillance protocol, implemented it, and clearly saw that surveillance protocol impacts survival. The biological reason behind that is that these tumors continue to accumulate mutations and become more aggressive over time. So even if they are low gradish in the initial part of their life story, they actually transform very rapidly and become high grade. So hypothetically, if you can treat them early, even a glioma which is sort of brewing and becoming high grade, and take it out, you may not actually have to do anything more in some patients at least, because you allow it to not transform and become more aggressive over time. And as you can see, the transformation in both brain and GI is pretty fast, over 5 to 6 years, unlike even leishmania where it can happen over decades. More interestingly, as we were working with global collaborators, not everybody could do the full intensive surveillance protocol with whole body MRIs and MRI brains every 6 to 12 months. So we had patients who could actually get only part of the surveillance protocol, the red ones over here. And you can see that even partial surveillance was actually better than no surveillance. So this was a learning. Again, it wouldn't have been possible to learn this in Canada or US alone, because then we would have been left with the graph which is here for full surveillance. But doing things with collaborators from across the globe helped us identify that even partial surveillance may actually be helpful in many settings, and that actually helps save lives. So I talked a bit about hypermutation and why immune checkpoint inhibitor Dr. Buffet and Dr. Tabori thought that would be helpful for our patients. The reason is that the tumor cell is an abnormal cell, and it should actually express abnormal antigens that are recognized by T cells, and the tumor cells would be killed off. But that doesn't happen because one of the venue mechanisms involves this PDL1, PD1 axis, where the tumor cell actually prevents the T cell from killing it off. So if we have drugs which were developed in lung cancers and skin cancers that could abrogate or block this pathway, then we could unleash the T cells to kill the tumor cells. And as you may imagine, with the hypermutation, all our gliomas and all our cancers did have a lot of neoantigens expressed on the surface. So the T cells were already there, and we just needed to take this break off to make a difference in the lives of a patient. So this is my patient from back home who presented with colon carcinoma with glioblastoma. And thanks to Dr. Buffet and Dr. Tabori's mentorship and advocacy, we were able to get nivolumab, and we had this immune reaction, which I will touch on briefly today, but then response, as you can see, with a prolonged survival for this patient with a good quality of life. So directly, the facts that were being discovered by sick kids could actually help my patient back in Kolkata, even in 2018. So when I came and joined Sick Kids as a fellow and then continued the research program under Uri's mentorship, we actually had the opportunity to summarize many such patients from across the globe who we treated together, some of them in Sick Kids, but majority from outside, including my patient over here. And we saw for the first time in recurrent glioblastoma, all the blue tumors here, objective responses, the white glioblastoma spot here disappearing, which we never saw even like with frontline treatments. And this was like recurrence after failing multiple lines of therapy. And patients, if you remember, everybody died at 1 year, most within 3 months, swimming in this swimmer's plot for more than 4 years, really impacting the overall survival, as you can see over here, at recurrence, mind you. So again, understanding the biology helped us use treatments that were already available for adult patients with lung cancers and skin cancers, and use that in our population to make an impact in the lives of our patients. So we did some biomarker analysis to systematize collaboration with physicians from across the globe, and found, as expected, that high mutation and high microsatellite instability were actually predictors for good survival. And we understood that there were a lot of T cells, there was a lot of PDL1 expression. So the T cells were already there, and we just needed a drug to take the brakes off, as I showed to you, to make the improvement in the lives of our patients. We also understood, and this is going a bit deep, that we knew that there were adult hypermutant glioblastomas which were not arising from the germline condition, but as a result of treatment with temozolomide, which had a lot of heterogeneity, and the checkpoint inhibitor trials had failed for these patients. And we wanted to know why. So we asked that question and found that when you acquire that as a part of treatment, then you only acquire that defect as a part of a swapclonone phenomena. So you can see here parts of the tumor which have loss of stain of MMR proteins, and part of the tumor which has retained stain. So it's an easy thing to imagine that these would the ones that would actually escape the checkpoint inhibition. And the other fact was that even these adult hypermutant gliomas didn't have the extreme mutation burden and the extreme microsatellite instability that we saw in our patients in the previous slides. So moving on, as we said, CMMRD is a deadly syndrome, and we can have multiple cancers presenting at the same time. So the unique thing about the syndrome is that because we know the biology, we know that all these cancers would actually have the same biology, the same high TMB, the same high MSI, and the immune infiltrates to help us treat them. So usually you can't treat a colon cancer and a glioblastoma in a single patient with different regimens and hope that something will work. But again, understanding of the biology, metastatic colon cancer with glioblastoma, you can see the disease disappearing, the bone healing, and the glioma staying stable for several years. So similar to my patient back home, it can actually impact multiple cancers if you diagnose them. And that's why we always recommend a PET scan before starting checkpoint inhibitors in CMMRD, because you can have adult ocal cancers lurking here and there, which you may miss if you don't do a proper imaging to diagnose everything when you start treatment for these patients. So I talked a bit about how our tumors are very, very immunogenic, and that's why immune reaction like this can be a problem, which in the previous years or era would have been taken as progression. But now we know, thanks to our work, that these are actually immune infiltrates that make the tumor big radiologically, and the patients can really become sick. But there are ways that actually you can manage them. You don't want to use steroids because then you suppress the immune system, but you can use maybe anti-VEGF to avoid steroids and make a good outcome by giving the immune system time to kill off the tumor cells while you manage and keep your patient stabilized from this big edema that has happened over here. And we have some biomarkers to identify who are the patients who develop flare versus who develop true progression. So as Dr. Buffet mentioned, this was a registry study, but it's important to clinical trials, but that's challenging as well. So in parallel to the registry study that I talked about, Dr. Buffet and Dr. Morgenstern here did a clinical trial, multicentric clinical trial in multiple countries. But with the challenges, we were ultimately able to accrue 10 patients. But even those 10 patients showed us that patients with recurrent glioblastoma surviving again for more than 3 years. And you can see the survival curves are pretty similar to the registry study. So this actually makes us think that clinical trials for these rare subsets may be challenging. You may not be able to accrue enough numbers because LMICs are not involved, where the huge population is actually there for us to make a difference in their lives or try to make a difference in their lives. But here it's costly as well. So maybe the way forward is to do the clinical trials as we do in high income countries, but maybe more look towards networks that we can do similar protocols, follow the protocol, but do registry studies and collect biomarkers in the same manner to fasten our pace of learning and fasten the impact that we can have in the lives of our patients. So a couple of slides about what we are doing now. As you saw, only 50% of the patients respond and 50% don't. And again, the biology, and I will not talk about the mice models that we have for these diseases, where we can actually understand test combinations and then take them to our human patients to see that, yes, even if you fail one agent, you can actually combine, because the hypermutation and several pathways, including RAS/MAP kinase pathway, are actually activated in our tumors. And that's why you can use combinatorial therapies for patients who progress on nivolumab monotherapy. And we have our paper under review for this right now. So we also learned, treating patients from across the globe, that delayed responses can happen with immunotherapy. It's not like chemotherapy, that it's cytotoxic, or even radiation treatment. But you can see the patient in our clinical trial who was actually progressing after 4 to 6 months and was sent home. But even without treatment for several months, when she came back, because she was alive, we called her back and did an imaging, the disease had disappeared. Because once you activate the immune system and you have an immunogenic tumor, you can actually have delayed responses, as you can also see in another patient over here. And because of the genomic instability and the mismatch repair defect, these patients continue to accumulate mutations. So you can see they are both high TMB, but at progression, the mutational spectrum was quite different. We did this by combining all the mutations and combining and comparing them in a Venn diagram. And you can see that over time, even when under treatment, the mutational spectrum has evolved at progression. That is also apparent on the morphology. But what that has helped is that now there are more T cells, and that's why continuing immunotherapy can lead to delayed responses, which is very unique in our patients. we are learning that all these tumors are not the same. There are good players, there are intermediate players, and there are bad players. And our focus over the next few years is to develop subgroup specific clinical trials for these subsets. This is a trial that I will talk about just because Dr. Buffet is leading this across 5 countries. And here it's a subset of patients who have extremely good outcomes because they are very immunogenic microenvironment with extreme TMB and extreme MSI. And we are treating them without radiation by doing surgery and immunotherapy upfront, which we did for a pilot study of 5 patients and found it to be a successful strategy. And this, you can see the 5 countries over here, including LMIC. You can see India and Turkey, maybe not LMIC, but definitely India is here. So other combinations in development based on the preclinical models and the studies that we have done in the lab and taking it forward as initially human pilot studies and then as broader or larger clinical trials through different consortia, albeit right now in high income countries, but hopefully in the future involving many other low middle income countries like the first trial. So it's not only about treatment, but how we diagnose these patients. And this is Brian, a PhD student in our lab, who developed a novel functional assay to diagnose RRD. You can see that this is very sensitive and specific because it's like a quantitative score that helps you diagnose RRD not only from tumor and blood, but we also could diagnose this set of disorders from the saliva. And sometimes immunohistochemistry can be challenging. And we did a pilot study with our colleagues in Lebanon, where IHC was ambiguous, but logic helped us identify that, yes, these tumors had RRD. We went back to the families, diagnosed CMMRD or Lynch, did appropriate surveillance and cascade testing for the family members, and found that this was very beneficial in helping the patients in the low resource settings because this is a cheap assay and it's very like robust and it can be done relatively fast. 96 samples can be run at one go. So that makes actually things cheaper. My last slide for the sciencey bit, which is to say that now we have identified that medulloblastomas can apply or have the same biology if they arise in the same germline condition. So if I saw SSHP53 mutant medulloblastoma like the patient that I had in Kolkata, it's a death sentence for most of these patients, right? But sometimes this can arise in the backdrop of hypermutation in a child who has same MRD. And you can see that multifocal relapse where there was no other treatment because it was after radiation and chemotherapy, disappearing with anti-PD-1 alone because we could identify the patient as CMMRD, go into the biology, identify the high mutation microsatellite burden, the T cells, the PTL1 expression. And if we can identify them, we can actually benefit. This is again at recurrence that we can make a huge difference because otherwise these are like fatal cancers, as we all know. So just to summarize, I hope I was able to share with you that what started as an initiative, again, led by Dr. Buffet and Dr. Tebori by doing these twinning programs, mainly patients from Jordan and the Middle East coming with CMMRD, that led to an explosion of knowledge for similar syndromes, which have the cancers with a similar biology, that allowed us to develop novel tools to identify in multiple cancer types and an inexpensive tool that can be implemented in low middle income settings as well. So that understanding of the biology allowed us to harness that information to develop or use therapies that were available not for children but for adults and improve survival for refractory metastatic synchronous and lethal brain cancers. And as we learn more, we know that these cancers are very unique, they are dynamic, and we are learning how we can use combinations to improve the outcomes for our patient. For people who have no interest in CMMRD and Lynch, I hope that what I learned is that understanding biology is very important for improving and optimizing care. And we can actually work together, and collaboration is a way forward. And collaboration not only means collaboration for like the low and the high middle income twinning program, but also working with your pathologist to see what you can do for your patients, even with the limited resources back home. So I will just end with this slide, which shows that how we work in the consortium. Translation from science to clinics is difficult. That's why we make it a point that we learn from our patients, do the experiments in the lab, and then feedback to our patients. And we do this through weekly consortium meetings. And we can do, thanks to the grants that we have right now, we can do free of cost consults and genomic and immune testing for many patients that we do from across the globe. You can see some of the numbers from last year. And of course, all of this can't be done without a huge team. and the mentors that I have been fortunate to have, as you can see over here, both in Sick Kids and back in Kolkata. And these families are the ones that make you happy at the end of the day, where you never expected survival, but see smiling faces after 5 years from what was supposed to be a fatal cancer. Of course, grantees are the people who pay the money for allowing us to do this is important. And as Dr. Buffet mentioned, it's always important to keep in mind your family as well. So I will stop here and I'm happy to take any questions. Thank you for listening.
Thank you, Anirban. Amazing talk. And I think you have a great mentor, a lot of mentors, and we could see a younger Eric Buffet in Anirban. So wishing you a very bright future and career ahead. And any questions for Anirban?
I see one question in the chat. Kieran asked how to differentiate a pseudo progression from a real progression in daily practice.
So thank you, Kiran, for that question. It's something that we are still learning. Radiologically, it's almost impossible, but as we learn and we have an excellent neuroradiologist who works with the consortium and tries to sort of help us guide that what this could be, it's important to be mindful of the tumor biology, because if you know it's a very extreme immunogenic tumor with high TMB and high MSI, it's likely to be pseudoprogression. The timelines are important. It usually happens early, but sometimes may happen like up to 70 days in our experience. And the last thing is that we have biomarkers in the blood, which I showed but didn't talk about too much, that we can identify that there are activated T cells and proliferating T cells in the blood to suggest that, okay, this is probably an immune reaction, but there is no obvious proof short of a biopsy which is challenging and often can't happen in the real life situation, to say that this is true or pseudoprogression.
All right. Thank you all for being here today. And I want to again extend it thank you to our speakers. I want to quickly share with you some slides just to go over some topics for the group. Okay, the first thing I wanted to remind everybody is that SIOP, the annual session, is coming up in October. The dates are October 11th through the 14th in Ottawa, Canada, and the deadline for registration is September 20th. Venkat and I are really excited to share a session that we're going to be co-chairing that's all about conducting clinical trials in LMICs. And so not just kind of the logistics associated with a clinical trial, but really thinking through things that we've talked about today, like collaboration, like working across networks and working across different regions to really advance the science, and what are the opportunities in an LMIC setting. And if you're going to be in Ottawa, please let us know, reach out on the WhatsApp, because we'd love to meet up with everybody who's going to be there in person. I want to also share this research opportunity for those that are interested in developing their skills as a clinical researcher. This is an opportunity that's hosted by Tata Memorial in Mumbai. It's called Credo. I can say that I've participated in this, and it's a really great educational opportunity, a week-long course for those who want to build a protocol at their center and get really great interactions with researchers and experts in the field. And so if you're interested in that, please go to this website. Their application deadlines are September 15th. This is just an overview of those applicants that would be eligible for participation. But if you have any questions about it, please feel free to reach out to me or others who have participated thus far. And then I want to say thank you again to our wonderful speakers who have really been essential for our neuro-oncology and global health session today. And then if you have any ideas for future speakers or for future sessions, please message us or send us an email in the WhatsApp. And feel free to send this link to anybody else who wants to be part of this group. And thank you again for everybody who was so flexible and nimble today as we were dealing with some of our technical issues. We really appreciate how dedicated the speakers are, as well as the members of this group. And so with that, I'll end and see, Venkat, is there anything else that you want to add for this session?
Thank you. It was just amazing, mind-blowing session, and everybody stayed back, and I think wonderful. We should have them back again next year. I'm sure many people are going to ask for the videos. Thank you,
Yes,
thank you,
absolutely.
both Professor Eric and Anil.
Yes,
you.
thank you both
Thank you,
so much.
Kathleen.
Bye.
Thank you, Venkat. Thank you.
Bye-bye,
Bye-bye.
everyone. Have a
Bye-bye.
great day.
Bye.